My name is Dr. Frank Speidel, and welcome to The Doctor Is In. In this program, I want to explore the interface of healthcare and society, and in particular, us as individuals in society. I want to focus on the opportunities and the challenges that are planted thick throughout healthcare as we experience it in the United States in the 21st century. Joining me today to speak on this is Professor Mike Howley from Drexel University's LeBeau College of Business. And the specific topic I'd like to explore today is how some quaint 17th century ideas in economics are alive and well and wreaking havoc in the United States of America in these early years of the 21st century. Specifically, something called a certificate of need. A certificate of need is the typical product of what I call best intentions paving company, where they create a road to a bad place with all the time having the best intentions. Let's go specific. In March of 2009, Natasha Richardson, the wife of a famous actor, happened to be on the actor was Liam Neeson, was on a learner slope skiing in Canada. She fell. She remained conscious, had some head pain, but remained conscious and refused care. Natasha refused care for about 4 hours, and her condition progressively worsened over that time period. Finally, an ambulance was called and she was transported, and she eventually passed away hours later. She passed away from a very treatable lesion from head trauma. The lesion was an epidural hematoma. The classic epidural hematoma allows you to have a lucid period where you're seeing pretty well, you have all your thoughts and your capabilities, you make sense to your surrounding friends, but then you go downhill and you will die from this if it's not treated. It's treated surgically. Now, the challenge of this is, in the United States, we have every year about 3 million people present to emergency department with closed head trauma or traumatic brain injury, better known as TBI in the lay press. When we see these people, not all of them have epidurals or subdurals, that are lesions that can be treated by surgery very successfully. It falls to us in the emergency department to figure out who do we call the neurosurgeon for and who do we just observe and make sure and send out with careful instructions. How do we go about separating those? Well, one of the challenges is when to call the neurosurgeons. We want to make sure we have blood that can be operated on inside the head. In the early 70s, when I came of age in medicine, there was only one study that could give a meaningful diagnosis to our suspicions of a significant intracranial bleed, and that was a carotid arteriogram. Now you're going to see a picture of a patient, and the patient in the picture is Megan from the movie The Exorcist. If you ever watch the movie The Exorcist, you will see a carotid arteriogram being done. It's that noisy thing where a whole bunch of x-ray plates go slamming through, sounds like the gates of hell opening, while somebody has injected into first the carotid on one side, then the carotid on the other side, contrast dye. The results of this contrast dye and all these multiple x-rays being taken will result in an x-ray film, which you'll see right now. This is going to be the next slide you see. You can see the blood vessels in the brain are outlined. We would determine from looking and knowing where the blood vessels should be normally, we could, by measuring angles, determine if there was a mass deforming the normal outline of the blood vessels. And that was the way we made the determination. This person needs to go to surgery for a mass in their left parietal region or in their right occipital region. This is what drove the decisions back in the early 70s. Fortunately, around the early 70s, there was a Brit named Hounsfield who invented a process, a heavily mathematical process, where simple X-ray beams could be integrated to create an image of the content inside of our brain. You'll see a slide right now that shows a normal brain CT. That's what we ended up calling what Hounsfield produced for us. Sir Rodney eventually won the Nobel Prize for this. These CTs have become a cornerstone not just for diagnosing head trauma, but for many things right now that we suffer from. Compared to the morbidity and mortality of that carotid angiography, they are infinitely less dangerous, and they have massively more content. Now you're going to see a picture of an epidural hematoma like what killed Richardson. And the next picture you see is going to be of a subdural hematoma. You can see in these pictures that the brain structure has been shifted to one side because of the increased pressure. That pressure is treatable once we make the diagnosis by a few burr holes, sucking out the clot and coagulating the bleeding site. In 1970s, when I was doing my training in my residency, almost every university in Philadelphia had a head CT, and we could get images of people that had significant head trauma to decide whether they needed life-saving surgery. Many major hospitals in the city of Philadelphia also had on-site head CTs. I finished my residency. I ended up my private practice starting in a beautiful community at a magnificent community hospital. Wonderful in every way. Imagine my surprise when I wanted to order a CT and we didn't have a CT scanner available. I just assumed that it was because the hospital was cheap and they didn't want to spend money on a CAT scanner. I know they cost millions of dollars, and I understand we got to make money and to keep our doors open. Was I surprised to find out, oh no, that wasn't the reason. The hospital wanted to buy the CT scanner and more. But there was a thing in Pennsylvania called a certificate of need. The certificate of need meant that before you did any big capital expenditures, added any new lines of services, it had to go through some people who were sitting reviewing proposals with the whole intent was to hold down the cost of health care. Now everybody knows health care is rising way, way too much, and we got to do what it takes to keep those costs down. So Frank, you're going to have to go back to bedside medicine. You can't use a CAT scanner out in your community hospital. This was obviously a bad idea. It didn't take too long for the certificate of need to fall into healthy disrepute among many people. The origins were back in the after the Second World War with a thing called the Hill-Burton Act, and then later with some modifications made to the Social Security Act that would require, at a federal level, every state and every region to have certificate of need programs where they reviewed expenditures by healthcare organizations to make sure that we weren't wasting money buying new toys. Around 1986, on a federal level, this requirement for certificate of needs was removed at a federal level. And shortly after there, Pennsylvania never bothered renewing their state certificate of need legislation, and it disappeared in Pennsylvania. Was I surprised this past August to read that in Delaware, 2 hospital systems had applied through their certificate of need process to put up freestanding emergency departments in Sussex County. Now, if you've ever been down in Delaware, there's a lot of dense population up north by Wilmington, but it gets smaller and smaller as you go down further. And if you think about it, when you have to travel a long distance to get to an emergency department, that may not be optimum. So 2 health systems wanted to put in freestanding emergency departments. This was denied by the CON organization of Delaware, and the name of that organization is I'll get back to that. Anyway, the request for the freestanding EDs was denied. Now, this is shocking. The concept that we're going to improve people's lives by denying the request for a freestanding emergency department is a little bit scary. What's even scarier is this concept of the central authority directing how the resources of society are allocated and used was kind of rejected in the 18th century. Specifically, the rejection of this concept occurs in Scotland, up in Edinburgh. Now, in Edinburgh, if you go from the castle and you walk down towards the Edinburgh Parliament, you travel along a beautiful highway, or not some highway, it's a beautiful road, an old, almost medieval road. It's called the Royal Mile. And as you pass down there, you will see a statue on your left-hand side as you head towards the Parliament. That statue that you see is a guy named Hume, David Hume, Scottish philosopher of the 18th century. And the thing we remember about Hume, which I think is wonderful, was he brought to our view of the world two concepts. One was empiricism. We look around us for evidence of how things work and how they fit together. We don't just accept the dictums of things that were told to us by our grandfathers and our great-grandfathers, our grandmothers, or somebody. We look and see how the world works around us. We embrace an empirical view. And he also invited us, Hume did, to to experience this empirical view of the world around us with skepticism, to say, how do I know this is true? One of my favorite quotes from him is, "A wise man proportions his belief to the evidence." Think on that. A wise man proportions his belief to the evidence. That means small evidence, small belief. Large evidence demands large belief. He also said that truth springs from the arguments among friends. And I think discussing things like this healthily in an open environment gets us to a better place. Now, the other statue, as you go by there, is a statue of Adam Smith. Adam Smith writes The Wealth of Nations and publishes it in 1776, the same year as our Great Revolution. He publishes The Wealth of Nations. And in this, Smith explores and invites us to understand how people going into an open and free marketplace, acting in their own best interest, optimize the allocation of resources that we use for production through a price mechanism where the marketplace decides between buyers and sellers the price of something that will invite more people to come in the marketplace with goods they've manufactured, or people to leave the marketplace. The beauty of this is, to the best of our ability to empirically observe, this creates the most efficient allocation of resources in society, as opposed to a top-down command economy where really, really smart people sitting somewhere decide on how many aspirin tablets we should have every year, how many CAT scanners we should have and where they should be located, or how many freestanding emergency departments we should have in areas where there's a long distance to travel to get to a hospital. Now, this idea of letting the market decide our allocation of resources, that's been proved time and time again. And as the Eastern Bloc economies failed during the 20th century, we have absolute evidence that command economies are lousy at optimizing the experiences for their citizens. So I find myself right now with Professor Howley by my side, scratching my head. Professor Howley, help me out. In the words of Buddy and the Elf, have the cotton-heady ninny-muggins gained access to control of our society, economy, and healthcare? What's happened that we're using pre-17th century thought?
Yeah, it's two centuries later, we're still trying to figure out who should decide who controls the resources in our healthcare system. Should it be a small community at the base of a mountain where empirically you have no need for a CAT scanner? There'll be no demand out in the woods at the base of a mountain, but the local community understands that there's a lot of people skiing, undertaking high-risk behaviors just for a few months of the year. So yeah, there is a need for that to be there. Who should decide? And this certificate of need process is simply a decision that, well, regulators will decide how you distribute healthcare resources.
Now, it's interesting you mentioned the community at the base of the mountain by the ski lift deciding on the presence or absence of a scanner. In the testimony that was going on down in Delaware, the mayor of the town, where they were talking about putting the freestanding EDs, he testified in favor of it. But someone testified against it. The CEO of the next hospital up the road testified against it. Why would he want competition? Professor, does competition affect price and quality?
Oh, yeah. I mean, and we're seeing this today where, in fact, we're losing a lot of this good, healthy competition. We're tending to consolidate our healthcare systems. So nearby hospitals don't compete anymore. They're simply part of a system. But, yeah, so particularly if you're going to take a strong empirical view of estimating healthcare demand, it's very difficult. There are all kinds of other factors, contextual factors that only the local communities know. So it's just very hard to run a predictive model on this stuff.
I think originally in Hill-Burton, the original language was driving towards local decisions about how health dollars would be spent, which is different than somebody 140 miles away deciding how many CAT scanners and EDs you get.
Yeah, and now on the other side, I do understand the need for some kind of regulation because there is this phenomenon of induced demand. So to use the CAT scan example, somebody could probably have data that if you put a CAT scanner out in the middle of a desert island somewhere, they'd be fully booked in 3 weeks.
I don't doubt that.
But, you know, just having an available resource somehow induces people to use it, even for serious things like having heart bypass surgery. So it's a very, very difficult answer. The issue that we're trying to get at is how do you balance the government control with the market control in healthcare? We have a fellow up at Drexel, Professor Rob Field, who has written a book called The Mother of Invention, arguing that healthcare works best when the market and the government work hand in glove. They work cooperatively together. But now we have a system with Natasha Richardson example points out, well, no, they're banging heads. They're not collaborating. They're banging heads against each other.
I'd like to come back to what you're saying. I couldn't agree more. I think there is a healthy relationship that
somewhere
exists. It exists somewhere in there. I think pharmaceutical industry / versus the aeronautical industry right now, the FAA. If you think about it, the pharmaceutical industry, the FDA, is careful to regulate very closely that drugs are made both safe and effective. And we look to government to do that because I don't know about you, Mike, I don't have the technical expertise to evaluate which drug is going to be safe and effective on the shelf. I need the FDA to help me do that.
Yeah, and they've proven quite good at that. And at the same time, especially in the past 10 or 15 years, they've become, they've been compassionate about it when there are people dying and they want to try. Maybe it's not going to work. I'm terminal with some disease. I'd like to try. And they have these compassionate use laws. So there's a little flexibility there.
I think that's a wonderful sensitivity.
Yeah.
And I think that's when the free enterprise system of pharmaceuticals trying to find the next new great drug that people are going to want to have, and government regulation, we all come out better. But, you know, I'm curious, how do such quaint ideas, such as top-down regulation of resources, it doesn't benefit the people of Sussex County, how do these ideas survive? What causes the continuance of things like certificate of needs? By the way, you know, I was surprised 35 states out of 50 still have certificate of needs. 1986, the federals dropped it.
You've been in this business long enough, and my ear is tuned. People tend to start these arguments with, doesn't it make sense to have a trained health economist to oversee this state's distribution of healthcare?
It's too important to leave to the market, isn't it?
Right.
Way too important to have market forces decide.
And, you know, doesn't it make sense? We have a tremendous problem with healthcare costs. Doesn't it make sense to have a regulator overseeing, like, how much money any given healthcare facility can bring in at a given time? And I may have told you, I have experience with this of our state regulators, when I was in Maine in the 1980s, state regulators determining how much a hospital could bring in any month. So if we got busy, it would look like we're going to bring in too much money. So we'd have to drop the price of a blood count or an x-ray. And the lab and the x-ray department took to posting daily price list. It was like a menu. So before I would order an x-ray or
you'd start gaming it, wouldn't you?
yeah, right. It's the natural. If you put people in that situation, they're trying to locally optimize, in the words of economists, trying to take the best care of the patients that they possibly can within the system. They're going to game it for the benefit of their patients.
The challenge does come about because that really smart healthcare economist I have, is he on the front line seeing things that are changing every day? Do you remember way back there was a time when heart attacks, we could just give some antiarrhythmics, we could give something for pain and some oxygen, and nature kind of took its course. Then in the mid-'80s, somebody, and I'm sure it wasn't somebody working for the CON, working for a CON, Certificate of Need organization, noted that we know that heart attacks are caused by blood clots, that if we gave something that dissolved the clot early enough, that blood vessel would open up again and the person wouldn't lose their heart muscle.
Right.
And that came about kind of organically, word of mouth. I remember I heard about it from a phone call from a colleague in New Jersey saying, "Hey Frank, you won't believe what I just did." And this was almost, a couple articles appeared, and then on our own we started to do it. How long was it till the American Heart Association adopted thrombolytics as part of a protocol to treat a heart attack?
Years.
It was years. It was about 5 or 6 years later with controversy.
And then with the balloon angioplasty, that took a huge amount of time to diffuse. And when I was seeing heart attack patients back in this Maine, I was in a 20-bed hospital. We used to brag about having 20 beds. We ran 5 or 6. But we saw a couple heart attacks a week, and they would never give us permission, a certificate of need to do balloon angioplasty or thrombolytics. They would say, you need to do that in a tertiary medical center. Well, we were hours from any tertiary medical center. We were it. It didn't make empirical sense, but the local knowledge of the community and the local geography, these patients are not going to get the care they should have if we don't get that CON, even though empirically it doesn't make sense.
And there's political pressures too, as remember from competing organizations. I was very proud of an organization that I was associated with shortly after I got out of the Navy. It's in a university town, one of our major university towns, in the shadow of Mount Nittany. And this hospital did not have interventional cath labs. And the board and the administration and principal members of the medical staff said, we need to be able to cath people when they're having heart attacks here. And that makes all the difference in the world. Now, this is a big expense. Cath labs, you can't just have one cath lab. The rule of thumb is,
Right.
Three. Yeah, the rule of thumb is usually, why do you need 3? Because somebody's on the cath table having an ablation of dysrhythmia-causing site, and all of a sudden the heart attack comes in. So that gives you 2.
But then you have to have one in case another.
Then you have to have one in case the bulb goes. So
right.
This commitment to do this is terribly expensive, and it's also expensive for people too.
Yeah.
We have to have incredibly highly trained people available to provide call, not just Monday through Friday, 8 to 4:30, 24/7, including Thanksgiving, holidays, Yom Kippur. We have to have that team and its backup team available.
Right. And the data is very clear that when you are this 24/7, 365 team, and you're doing it all the time, you deliver excellent
You
care.
get better, don't you?
Yeah, so, for Natasha Richardson, if only she had been injured near a hospital that did craniotomies all the time, that would be the ideal. But given that, shouldn't there be a way? How do you extend that care out to the hinterlands where people are and where people are recreating and living and working and traveling? Is a tension. Nobody's figured this out yet, but how do you balance that? And now, in the midst of this dance, of this balancing act, you plop a regulator in, and that tends to slow things down.
Absolutely. And remember, they're driven by cost. It's interesting that the governor in Delaware, he made the comment, in reviewing these applications, the committee for the CON came up with the statement that this was against Governor Carper's desire to cut down on the use of emergency room resources, because that's the most expensive way to get care.
Right.
Now, I know these are good people with good intention, and I'm sure Governor Carper wants the best for his people, the people of Delaware, but the best of intentions sometimes get in the way.
And he's quite correct that emergency room overuse is a real problem. But centralizing and limiting ER access geographically is not the solution. We have to rethink our healthcare system so it can for ways that it can extend its reach. Telemedicine is the big proposal today, and it has its proponents, it has its drawbacks, but there has to be some capability to do something at the point of care.
In relation to Natasha Richardson, when some people were asked in the Canadian health system about it, one of the comments they made was that we just don't have the resources to evacuate. We don't have the medical evacuation capabilities in Canada that you do down in the United States. And again, that's a conscious thing, central planning of how much resources we're going to have there. I'm going to cover a couple other things. Now, I'm beating up on this Best Intentions paving company that is doing all these things in healthcare. Do you see that elsewhere in United States healthcare, where we have this Best Intentions are running amok?
Oh yeah, I mean we see it technically, and we see it on the service delivery side. We embrace therapies. We talked about the balloon angioplasty and thrombolytics as being an intervention that really worked and really saved lives. All the time we embrace therapies that don't pan out. Bone marrow transplant for metastatic breast cancer, for example. Mm-hmm. We try and fail. That's how our system is. It's experimental.
This is such a good topic. I'm going to beg you to come back some other time and talk, because it's getting to the end of the time. I want to thank you out there for listening and taking something away from this latest episode of The Doctor Is In with Professor Mike Howley and Dr. Frank Speidel.
Thanks a lot,
again,
Frank.
Mike.
It's a
Appreciate
pleasure.
it.